Start streaming. So is this going to pick up the local mic again, like it did?
No,
just the external one. Okay.
Yeah, I mean the second mic is completely down
now.
But
Okay.
it wasn't like when I ejected just now. It wasn't. What's that?
It's live.
Yeah. But it wasn't down before. Here we go. Perfect. Sweet. The broadcast already. Are you hearing us there, Carl? Can I talk to you on it?
Yeah.
Put your headphones on?
40-second delay.
Yeah. Put your headphones on and wait 40 seconds.
Can I put this on?
Yeah, sure. I can hear him giggling.
Hear the tapping?
It's not sure. You shouldn't be picking up this video.
But it is.
Two, three, four, five, six. 2, 3, 4, 4. 1, 2, 1, 2, 3, 4.
This mic just unplugged it now.
Yeah, unplugged it. Can you hear?
I'm picking up.
Okay.
Yeah. I'm getting like from that mic anyway, so yeah, it's fine.
That's fine. Wait, so the second one's gone?
Hopefully, we'll find out in 40 seconds.
We remove
Guys?
it. We remove
You're
it.
not allowed here.
I know, so it shouldn't be.
No?
Shouldn't be. Yeah.
Do it aside, especially VIPs who need to get down there.
No, I can still hear us. I don't know where it's coming from.
Which one?
I can still hear us. After Mike unplugged it.
So I didn't
Four.
understand this way. Not really turn it down, but I was. But like,
Would it be a microphone?
when I was in the office, I didn't know it was any.
4, 5, 6, 7, 8, 9, 10. 1, 2.
In the office.
Okay.
Did you hear?
I didn't, but like when I was here, and you could say when you're changing tapes, you could hear like.
Yeah.
Yeah.
2, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2. 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2. 2, 3, 4.
I know which footer you're going to be speaking in, so maybe we can do it that way.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2.
Okay.
2. 1, 2, 1, 2, 3, 4, 5, 5, 1, 2, 2.
What's the plan?
I just want to know where to direct my knees.
Easy chair.
So you're here. This is where you're sitting, correct? Sorry, I just mean that I need to have, I don't need to know the start. No, there's nothing I can do. They're all working, I know that. I'll have to work it for them.
All right.
From their chairs, or they come up to the
Sitting here anyways, right?
It's nicer. What do you think?
Oh no, he's gonna make sure they work the way they're supposed to.
Yeah.
Okay, I don't know where to fit this properly in the sense that just want to go forward to all right, so you can start this in, yes. No, just give me 2 minutes, please. No, I just got a mic and we're missing somebody.
yes. I wasn't arrived yet.
Oh, he's a lawyer.
No, I need to point towards you more than anything. I can see.
So he also has a very large voice. He can also hold it
You know what?
down.
I'll do it there.
Worst case scenario, now,
Yes?
now trip it and hold it in your hand.
No, don't do that. That's not good, actually. Well, I know, but they're not made for that. So hold on. You just listen up. As long as they get the time, just somewhere here. That's it. It's not live. All right.
que decir cuánto te quiero, que te quiero, que te quiero.
We letting you
Es que no pensé que tú existías.
right here. Good.
Y es que no pensé en conocerte, pero te encontré y siempre ves. Me enamoré, me enamoré, me enamoré como nunca. Y es que yo creí que ya era tarde, que ya mi ilusión no volvería, pero te encontré y ya tú ves. Me enamoré, me enamoré, me enamoré como nunca, mi amor. Yo que ya creí que no era un niño para amar, he comprendido que mi alma aún es joven. Yo que ya olvidé la forma fácil de besar, he vuelto a recordarla de tu boca. Y es que no pensé que tú existías, y es que no pensé en conocerte, pero te encontré y ya tú ves. Me enamoré, me enamoré, me enamoré como nunca. Y es que yo creí que ya era tarde, que ya mi ilusión no volvería, pero te encontré y ya tú ves. Me enamoré, me enamoré, me enamoré como nunca. Pero te encontré y ya tú ves. Me enamoré, me enamoré, me enamoré. Ay, como nunca, mi amor. Gracias, vida mía, por llegar a mi vida. Cuando más falta nacía un amor. La diferencia de la noche, lo que importa es el amor. Me enamoré, me enamoré, me enamoré. Muchas gracias, querida, por llegar a mi vida. Me enamoré, tanto tiempo esperando un amor, que en ti yo lo encontré.
Joel López.
Quisiera decirte esta noche lo que siento, pero estás tan lejos esta noche, tan lejos. Quisiera dibujarte con líneas de colores y al grito de la noche hacerte realidad. Quisiera tenerte esta noche, esta noche. No puedo arrancarte de mí, no puedo arrancarte de mí. Me aprietas el alma, me arañas el sueño,
amiga, saluda amigo, saluda vecina, saluda vecino. Cuando Palito no viene la gente pregunta, ¿dónde está Palito? ¿A dónde tú estás, mi tío? Palito está conmigo, ahora llego yo. Nadie me pregunta, Palito, Palito conmigo. Llegó Palito, está dulce. Llegó Palito, está bueno. Palito de coco, palito de coco. Mi coco, coco está dulce, dulce de coco. El coco, coco está bueno, bueno de coco. Coco está bueno, bueno de coco. Dale, baila, 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 baila. Baila, baila, baila. Coco, coco está dulce, dulce de coco. Ya tú sabes.
Wow. What a full house this is. Just so you know, this room accommodates for 400 people. Now, when we were going to have the panel at the beginning, it was a smaller room, and speaking with my team and telling him the amazing people we will have as panelists, also the amazing topic that we are about to discuss. I said, 150 will not do it. Let's try to see if we can get, a bigger room. And here you go, 400 people in this room. Congratulations for joining in the dialogue. So, as we draw to a close on our 90 years annual general meeting, we shouldn't be surprised that once again, RNO is at the forefront of dialogue. We have an excellent, excellent keynote panel presentation for you this morning, End of Life, Voices and Perspectives, to be presented by a panel of distinguished panel guests that will be introduced by a moderator that to us at RNO is an important person. Her name is Carol Gore, and Carol has been a journalist for more than 35 years. She has worked for a variety of newspapers, news services, and magazines on Parliament Hill, Washington, and in Toronto. She is currently a columnist at the Toronto Star, and she has been in events with RNO on several occasions. Thank you, Carol, for your generosity. And on several occasions when we have dialogued about important, important topics. So I am delighted to pass to you the microphone to Ms. Gore.
Thank you very much, Doris. And let me begin by saluting all of you for initiating a public dialogue that none of our political leaders has launched yet. It has now been 7 weeks since the Supreme Court struck down Canada's ban on medically assisted suicide. The court, as you know, gave Ottawa and the provinces 12 months to draft a law that would guide medical professionals, protect vulnerable Canadians, and give competent adults facing intolerable suffering a way to hasten their death. So far, there has been no political action from the federal government. Liberal leader Justin Trudeau, to his credit, proposed that an all-party committee look at the issue, but the motion was defeated by the Conservative majority in Parliament. At the provincial level, Quebec already had an assisted suicide law before the Supreme Court's decision. The other provinces are looking to Ottawa for leadership. In the absence of such leadership, RNAO has courageously stepped forward. I consider it a privilege to moderate today's panel. My role is not to air my personal views. It is to ensure that we have an open, respectful conversation that sets the tone for other Canadians wrestling with this morally and emotionally charged issue. I will intervene only if a speaker exceeds the 3-minute limit. They are all aware that they have 3 minutes to speak. To kick off the discussion, I would like to invite Rahul Agarwal to the microphone. He is a litigator specializing in constitutional and at the Toronto office of Norton Rose Fulbright. You can find a more extensive biography in your program. Rahul, and you don't need to come up here.
Thank you. So I thought it would be useful to kick off the discussion with giving everybody an overview of the decision, so we had a good grounding for the more important dialogue to follow. The key issue in the Carter case, that's the name of the case, Carter and Canada, of the Attorney General of Canada. The key issue in the case was the constitutional validity of two discrete provisions of Canada's criminal code. So two provisions of the criminal code operated to effectively prohibit physician-assisted suicide. The first provision was that no person can consent to somebody else hastening their death. And that's a paraphrase of that particular provision. And the second provision prohibits the aiding and abetting of someone else's suicide or the taking of their own life. So those two provisions together criminalized both individuals who sought to end their own life and those who would seek to assist those individuals in ending their own life. So those are the two key provisions. The court's decision really has three main points. The first component is that the court found that the criminal provisions violated individuals' right to life, liberty, and security of the person. And that is a right that's guaranteed under the Charter of Rights and Freedoms. The main piece of the court's analysis with respect to the life, liberty, and security interests was that the criminal law unfairly impeded upon an individual's autonomy to control their own bodily integrity. And that has been growing through the jurisprudence, and particularly at the Supreme Court of Canada level over the past many years. The court is very focused on individuals' abilities to control their own destiny, to make choices about for themselves, by themselves, and particularly about their own body. And specifically within the realm of medical decision-making. And if the consequences of that are dire, negative, serious, and can even end in death, the court always errs or seems to err on the side of the individual. So it's an interesting kind of libertarian approach to personal rights. So that's the first part. The second piece was that the court found that the objective of the law stretched, or that the law as structured went too far with respect to its objective. So in order to find a breach of the Charter under Section 7, not only does there need to be a violation of life, liberty, of the person, but the law also has to be overbroad, go too far. What the court found was that the objective of the law as structured was to protect vulnerable persons, but in fact the law went far beyond that and captured everybody within its ambit.
Okay,
So,
I know 3 minutes is a very stringent limit.
sure, okay. So I'll round that off by saying that the last piece, in addition to those first two pieces, was that the court found that there would be adequate safeguards to protect against vulnerable people from being induced or coerced into taking their own lives unfairly or in a manner that wasn't their own personal decision. So that's a very of the case.
Thank you very much. Next, we'll hear from Dr. Vanessa Burkowski. She is the president of the Registered Nurses Association's Board of Directors. Vanessa.
Thank you and good morning. in a similar vein, I thought I'd start off the conversation by setting the context for the resolution that was brought forward that actually brings you all here today for the public dialogue.
A year ago.
A year ago, yes. So RNAO as an organization that is values-driven and that recognizes the rights of the public to inform their own destiny, approaches to care, no matter what that care might be, no matter what sort of approach that patients and the public recognize will meet their needs. RNAO is there to support that enables that conversation to happen, and today is the starting point for that. The resolution was taken up to do just that, encourage the conversation. It wasn't a resolution to suggest a pro or a con to the issue of euthanasia or suicide, or as the law now calls it, physician-assisted death. It was really about enabling people from all walks of life to bring forward their diverse perspectives on the matter, to help inform a principled framework that moves forward as the legislation is implemented in the field. And so what today is really about is engaging all of you and starting the conversation, getting the ball rolling out there in the community. The expectation is that today will be exponential, that you will go home and you will have conversations with your own family and friends, with your colleagues, with your peers, with other respective organizations that may want to have a say, that may want to have their say in this public debate. And so for me, this is an incredible day of opportunity to share perspectives that will help guide decisions that are made as the legislative and the regulatory frameworks are being put in place. So thank you all for being here, and I look forward to your perspectives this morning.
Thank you very much. Our third speaker is first. She is president of RNAO's Palliative Care Nurses Interest Group. Leslie?
Thank you. Good morning. First of all, I do want to thank RNAO for not just doing this, but inviting the Palliative Care Nurses Interest Group to be present. It's a bit of an irony, actually, that we've come at the end, because one of the objectives of the Palliative Care Nurses Interest Group is to promote palliative care. And we want to be involved in people's care much earlier in the trajectory, not just at the end of life. And so the perspective I bring is really to inform you about the state of palliative care in Canada. We are ranked 9th in 40 countries in terms of quality palliative care. I know that we're certainly ambitious. We're even more ambitious, probably in Ontario, and 9th is simply not good enough. And the 4 dimensions that were measured were access, the environment, education, quality, and they all funding. So there's a number of different indicators that we really do not do well on. And I just wanted to bring a few facts to you that you may not be aware of. The decision is often driven in terms of choice and end-of-life issues from fear. Fear of what my death will look like, fear of what my family will go through, fear of what that experience will be. And the truth is, in Canada, we pay for end-of-life care. 70% of patients that are dying die in acute care facilities. 15% of those that die in acute care die in ICU. That's simply not acceptable. The other component too is we still struggle with basic elements of palliative care service delivery. It's multidimensional. I am going to speak predominantly about the clinical component, the physiological, and the access to good symptom management. And there are many physicians and nurses and other healthcare providers that are wary of providing opioids. Many palliative care physicians themselves do not have a license to prescribe methadone. And coming from the UK to Canada 12 years ago, where UK is ranked number 1, I'm just going to give a little plug for that, but you know, and I certainly know that we did much more aggressive, interventional, and the access was unprecedented. So consider this, consider between 70% and 96% of patients that need palliative care expertise. Because there's a nuance here that just because you're present when somebody is dying does not mean that you are delivering palliative care. And just because you're in a palliative care role or a clinic does not mean that you're delivering excellent palliative care.
Leslie, you're getting near your limit.
Really? Oh, let me just. Oh, they've turned off my mic too. It's quite the Oscars. Hey, we're a tough crowd. They're a tough crowd.
You will get a chance to speak later in the question and answer. And I do apologize for cutting people off. It's designed so that you'll have a chance to ask questions later on. We're now going to hear from Michelle O'Rourke, who represents the association's Parish Interest Nurses Group. Michelle.
Thank you. I, too, would like to thank RNAO for beginning this discussion and for asking us to be a part of it. I have a little bit of a different background in my nursing career. I spent a lot of time in critical care and emergencies, so I've seen a lot of suffering and death. And I kind of came into understanding palliative care and studying palliative care from the psychosocial spiritual perspective. I also studied theology and spirituality and have worked in pastoral care. And I think what we have to remember is, and thank you all for coming out, we all have questions. We all have different perspectives to bring to this discussion. And I think the really important thing is that we're heard, that as nurses who probably came into the healthcare system because our whole desire and drive was to companion people, to help, to be there for those people who were suffering. And, you know, I think in the last 50 years, we've really medicalized not only dying, but aging as well. Dying right now is kind of a failure of acute care medicine instead of a natural part of living. So how do we get back to being able to say that, you know, I think a society is how it takes care of those who are suffering, how it takes care of those who are dying, says a lot about who we are as a culture, about who we are as a healthcare system. And we know that there are many deficiencies, and Leslie named in particular the fact that over 70% of Canadians do not have access to this specialty. That doesn't happen 2 days before you die. We have what we call in palliative care the surprise question. If we're meeting with a patient, loved one, would you be surprised if this person died in the next year? And if the answer is, what are you helping them, how are you helping them to do that well? How are we helping them to do that well? Not just the pain and symptom management, but spiritual peace. And I think we really have to, that what does this say about who we are as a culture and as a society? Many, many sides and many, many voices at the table that need to be respectful. I think if we look back, all of the wisdom traditions would say that we look at life as precious, we look at life as sacred, we look at, and our healthcare system is built on the fact that, you know, life is important. And I think I have fears about the fact that, you know, if we adopt this, and no matter how many safeguards we put into place, will we be able to manage this as a society? How will my grandchildren die in another generation?
Are you near the end, I hope?
Yes.
Very much. Our fifth speaker is Michelle Taylor, who will be familiar to many of you from her 7 years as national health reporter for CBC. She is now a physician assistant at Toronto East General Hospital, and also the widow of Dr. Donald Lowe. Maureen.
It's Maureen Taylor, yeah. I didn't come prepared with anything. Maybe I'll just, quick show of hands, did anybody ever meet my husband or work with him? So wonderful. So I knew Don Lowe before, and many of you probably saw him on TV from time to time, and then you saw the video that he made 10 days before he died. You can see physically the toll that the brain tumor took on him. And maybe you can hear in his voice the psychological toll that hit. I never left his side from the night that his diagnosis by MRI was given to us, up to and including the night he died. I slept beside him. Don home with wonderful palliative care. We gave him palliative sedation. Shortly after the video was made, he lost the ability to walk and swallow and talk, and so it was decided that the kindest thing that can be done at that point is to put the patient into palliative sedation and not offer fluids or anything else. So what killed Don was not the brain tumor. It was that we cut off fluids to him and his kidneys shut down, and then he died 8 days later. So that is medical assistance in dying. It's the kindest option that was available to us, but what Don wanted was not to have anybody say you have to eke out the rest of your existence when you can't talk to your family and do anything for yourself, and you have to be in a coma, that he wanted to be able to choose when to go. It wouldn't have been that long before that date, but those last days wouldn't have been so heartbreaking. That's all. Thank you for having me, by the way, too.
Let me add my thanks and introduce Dr. Peter Van Bogart, who's joining us today from the Division of Nursing and Midwifery at Antwerp University in Belgium. He also serves as a member of the International Advisory Committee of Registered Nurses Association in Canada. As some of you will know, his country allows a carefully defined version of medically assisted suicide. Please go ahead.
Thank you. To understand the case in Belgium, it's important that we have since 2002 3 acts. The first act is an act about patient right. That's the act that says that you can refuse treatment. Then you can formulate a living will. When you're mentally incompetent, then representative can refuse treatment for you, such as artificial feeding, intubation, ventilations, and so on. That's the first one. The second one, it's about palliative care. Federal network of palliative care, you have the right to receive palliative care any place where, at home, in a hospital, in a long-term facility, as you wish. And we talk also about supportive care because we try to start very early. Palliative care is something people think, now I'm gonna die. And it's very important to start earlier to support people physically, but also mentally and spirituality. The third act is the act about euthanasia. That's the name, that's what we say, euthanasia. I was not aware about suicide, assisted suicide. It's an odd term for me, it's in Belgium, euthanasia. And you can request euthanasia when you have a non-curable disease, when you suffer unbearable, and when you are terminal, to proceed euthanasia, and it will be proceeded by a physician, so it is medical assistant. Another situation is when you are not terminal, you have a non-curable disease, you suffer unbearable mentally, you can do a request for euthanasia. You have to wait 1 month. And very important for both cases, it is your request, well considered, with a review of your physician. The case of the non-terminal status of a patient, you need 3 physicians, and the third one is a psychiatrist, a specialist of your disease. I think it's a very careful law, and the 3 are very important. Patient right, palliative care, and then you can decide to proceed euthanasia. At the moment, in 2013, we had 135 cases in a month. It's about 1,800 people. It's less than 2%. There is a difference between regions. The Flemish part region of Belgium, 80% is registered euthanasia. In the French part, 20%. It's also about culture. You can have a legislation, but it's also awareness. And that's also important.
Are you near the end?
Yes.
Thank you. We are now going to move to your questions, I am sure, especially since I had to cut people off in mid-flight. Many of you would like to pick up the threads. We have 2 people who are going to be wandering around with floor mics, 1 and 2. So if you would like to ask a question, just raise your hands. They will get to you, and I'll recognize you. And just before we do that, out of interest, the organizers would like to know, and I'd kind of like to know too, how many of you are nurses? Vast majority, not a surprise given the meeting. How many of you are other medical professionals? Significant number. Good. That's interesting to know. All right. While I am waiting for hands, I am going to ask Dr. Burkowski a question. Did you hear enough common ground in this morning's presentations? We obviously had a wide range of perspectives that you think it will be possible to move forward with a framework that can accommodate everybody's needs?
I don't think I'm going to say thank you for that question. I did hear some very common threads. The first is around palliative care. I think there's a clear recognition that we need to have a very, very fulsome approach to helping people both begin the journey and end the journey across their lifespan. So we know that in Ontario, and I think probably across Canada, a very fragmented system of with palliative care. Palliative care does not begin, as my colleague said, at the end stages of life. It begins at a recognition point of where people will need greater supports and services and specialized supports and services. So I think the first issue is around palliative care. That resonates with lots of the conversation that has happened here and I think out in the public. I think the second piece of it is that as in Belgium, there's a very thoughtful, staged approach to helping people come to a decision for euthanasia in particular. That we need to have the pieces in place that allow people to be very informed and to allow people to receive as much support and service as is possible within the system. And I think that's the obligation of the system, to set that up for people first, so that when people get to a place where euthanasia is their choice, it is a choice purely based on their autonomy. It is not a choice because they don't have an alternative. And I think that's what's significant as well in terms of the thread that crossed amongst all of
I
them.
will add one thing. It's in Belgium they strive to concept of decision. The patient decides, and not the concept of care. Don't misunderstand. The concept of care in that discussion means the physician or nurses of healthcare workers decide what is best. And the decision is the patient is informed, asks questions, talk with his family, and can take a good decision whatsoever.
Thank you very much. Okay, I would really like to hear, we've got a question over here, I believe. Can you get down to the woman in blue?
Carol? I'm ready to go ahead.
Fine.
Hi.
Go ahead.
My name's Erin. I'm from Ottawa. I just graduated nursing, but have been working in pharmacy for the last 10 years. Our pharmacy is the service provider for Champlain, Southeast, and now Central CCA. Our pharmacy is the one that rolled out as the symptom management kit and symptom response kit for palliative care nurses to have access to end-of-life drugs in the community. I'm not sure, I guess this is more of a statement. Leslie, you spoke to quality of care and access to quality symptom management. Right now in the province of Ontario, patients only have access to end-of-life drugs based on prescribing rights by a physician. That needs to change. There's no reason that the Ontario Drug Benefit Program can't code patients as palliative so that people in rural communities aren't paying hundreds of dollars for comfort in end of life. And I don't know if that is something RNAO can consider to facilitate, or, but that is a massive issue, I think, in Ottawa. Well,
yeah.
Leslie, can you talk about that?
Yeah, I'm very happy to speak to that, and thank you, Erin, for the statement. It's true. Access to medications is very limited, and the symptom management kits alone are multifaceted because you are not leaving those symptom management kits in the hand of necessarily palliative expertise or highly educated and prepared palliative care nurses too. The community nursing situation and community care, there was a recent it's actually available on the RNAO website, but as Vanessa said, it's extremely fragmented. We're talking about basic access here, and let's not misunderstand, you know, we love patients. We love it. The gallbladder in bed 4, the palliative patient. Like, we have to stop labeling. Palliative care is an approach. And I was fascinated to hear your definition, actually, of non-curable is not terminal. I would say anybody with a life-limiting progressive illness, which is probably 80%, 100% of chronic disease, and certainly many cancers now, should have access to a palliative approach to care by expertise, access to the full range of treatments, the full range of supportive care from psychosocial, spiritual. It's not just about medication, but medication is one of the basic elements. If we haven't got that right, we've a long way to go. So this decision, actually, for me, it's like a firecracker up the backside of this healthcare system, because if we do not do a great job at improving palliative care, to speak to Vanessa's point, you've got two options. Mediocre, variable treatment, which is very, you know, there are pockets of excellence, but still, generally, option 1, fairly bad. Option 2, even. Thank you for raising that point.
How do we work this? Hello. My name is Mahogany Hines. I'm a third-year nursing student, actually, of the Brock Loyalist collaborative program. I actually just wanted to call into action, actually very similarly to what Leslie is saying. I don't think that we receive adequate palliative care education. I think that we really need a lot more to make us able to talk about the situations. Like, as somebody who wants to go into palliative care, that's actually where my passion lies. I think we need an action for more comprehensive, integrative palliative care in nursing academia, as well as the stigma associated with palliative care and end-of-life care. And we need to start communicating about it right from the educational level, because we can't help our patients if we don't even know how to talk about it ourselves. So,
Thank you. Now, has someone finally got a microphone to you?
From Region 10. I think, Leslie, you bring up a very important point, because distinguish what is palliative, end of life, chronic disease management, because I think sometimes I hear palliative for everything. Because if you have dementia, it is considered a progressive deteriorating disease, and at some point, we're going to palliate to your needs. Yeah. But you know, how to engage the person and their families against therapeutic relentlessness. There's a program called PATH, and that's called a palliative something, therapeutic harmonization. It's having that dialogue with the person and the family about, you know, if you do have this, what are the risks and benefits? Because people only see that as, I'm going to get better and get better, and I want the treatment, but, you know, we're not really having that conversation sometimes to tell them what the actual reality is, because there's side effects to the medications or the treatments, and is that how they do want to live? Because they're not dying, they are living, and so helping them live with dignity. That's my first point. The second point is that some of the nurses have approached me and said, you know, when the doctor's going to prescribe this medication at the end of life, who's going to be giving it? Is it the nurse who's going to have the accountability and the responsibility of administering that medication at really the end of life? Because I don't know if any nurse wants that responsibility. So those are important points that we need to bring to the forefront, because I know there is pressure on right now that I think in February it all has to come together in terms of what the new regulation or whatever it's going to be. And then, you know, I guess this is where the voice of the nurses is really important, and moving forward and taking action so that they really know where we stand and what our perspectives are and what's the framework. So anyways, I would just like to conclude that that's kind of my remarks at this point in time. Living with dementia, again, it's a palliative progressive deteriorating disease. So you can have diabetes, you can have arthritis. All of these are, you know, as we are getting older, we have a little ache here and ache there, and then all of a sudden something pops up and we got to deal with it. And how are people helping us cope with that journey? And I think that's what you pointed out, is how are we having that conversation to help people along their journey, their life journeys. Thank you very much.
Thank you very much. In my not very pleasant role as timekeeper, I am going to let you all know now that we have to end this session at 12:30. So if you can keep questions really succinct, that would be a huge help. Thank you. And we'll have one from here.
Okay, my name's Debbie. I'm from Region 10. I'm speaking as a family member. First, I'd like to give a shout out to the Guelph area palliative care team. I lost both my parents years ago, and they were fabulous. Sorry. I am dealing with my in-laws right now, and their struggle has been that palliative care is defined as 6 weeks prior to death. And nobody, I defy anybody, when that 6 weeks is going to happen. The other issue that they are struggling with is location of death. And what their choice would be is either at home or in a hospice setting. To hospice, especially if they're hospitalized, to being able to move into hospice is a non-starter. And this, I think, has to stop. I think we have to be able to provide access to place that is of choice, as well as looking at choice of timing of death if that's what they choose to do.
Thank you very much. Can we get, thanks.
Okay, so I think I'm next. I have to thank Paul on emphasizing the importance of assessing the meaning of the client's request for assisted suicide, so we don't just take it at face value. But my main concern is if only the patient's choice counts, what happens to the accountability for ethical decision-making that the nurse has? Because in my practice as an advanced practice nurse, I have people who tell me, I didn't know I could say no to that. So once something becomes legal, there's a moral obligation, a social obligation in the team to proceed with whatever the client is asking. And I think it diminishes the accountability and the capability of the nurse to make an ethical decision, taking many factors into account. And this bothers me because we made a big emphasis yesterday on diversity in profession. I think we have to preserve and value nurses' ethical accountability and nurture that.
Thank you very much. A word from the podium. We're going to be extending this by 15 minutes, so there is a very good chance some of you will be able to get yours.
I would just like to add to this discussion about of reflection on access to health care for people who are not just experience end of life, but living with a chronic disease. And my daughter is in her mid-20s, has had Crohn's for over 3 years. And we are indeed in a society where we are trying to reduce emergent transfers. We encourage people to be at home. They do better. But the other side of that issue is that I think it drives people to look at end-of-life assisted suicide as an option to end the burden on the family. Financially, I was a supporter for my daughter. Her health care cost this summer cost me $10,000 because they would not admit her to a hospital. I am a palliative care nurse. I've been manager of a palliative care unit for 4 years in Windsor. And I was very strong in advocating, and I'm knowledgeable. So my suggestion is this is not about lack of knowledge. I was knowledgeable. I could not break down the barriers to get my daughter the treatment she needed, and it resulted her being in the hospital on her deathbed. I took her to Emerge for pain management, and she was labeled as drug seeking. She has an honors BA in psychology, an honors BA in French, and she's working on her master's in social work. And after all of her suffering and the cost of the drug, she asked me to look into assisted. When we looked at the time, it was only available in Oregon, and the stories we watched on the television were heartbreaking. And it was a story about a 60-year-old man who had prostate cancer. He had a diagnosis prior to assisted suicide being legalized. When his cancer reoccurred, the insurance company refused to pay for his ongoing treatment and desire to live, but offered to pay for his assisted suicide. We also have a healthcare system. My mother-in-law was in a long-term care home. She was short of breath. The palliative care physician gave her Dilaudid to manage her dyspnea, when in fact she was having a heart attack and she ended up with congestive heart failure. But because of ageism, we help people die, especially in long-term care. The doctor would not transfer to the hospital because we're eager to divert emergency transfers. We had to wait till the doctor left the facility, and and the nurses were very good at advocating, but the doctor wouldn't allow it. When she got to Emerge, she was admitted to ICU. Second day in ICU, they said she had a home bed, and they sent her home. Once you're back in long-term care, you're with non-registered staff who don't understand the cardiac rehab protocol, and they walked her to the dining room every day for her meals. So my suggestion is we have a flawed healthcare system. Both my mother-in-law and my poor 27-year-old daughter last year both opted for assisted suicide because she and my mother-in-law could not afford to see the pain and the financial costs to living at home. So end-of-life care is great at home if you have appropriate medical support and the financial resources. And I want to say on a personal note, I had 5 weeks vacation. I used all my vacation to care for my daughter, and I was looking into a leave of absence with no pay and still paying for her care at home. So it's a very sensitive issue, I think, and we need to be very careful that we're providing the right care and people aren't opting this because they're frustrated.
Thank you very much for that question. I am sure you have spoken for thousands of voice-arians. Yes.
Hi, my name is Carolyn Gludish, and I'm with Holland Bloorview Kids Rehabilitation Hospital. This is a question for Dr. Van Bogart. With the right to refuse treatment and the right to receive palliative care, and you can request euthanasia, I'm curious to know, looking at it through a pediatric lens, what issues and stumbling blocks you've encountered in Belgium.
Since 2014, the Act allows euthanasia for children when they are in a situation of sound judgment, when they are not curable, and when they suffer unbearably. And it's about very, very low numbers, and it's exceptional. It's a huge debate in Belgium. It's very emotional. It's allowed now, but it's about very low numbers and exceptional situation, and we have to watch that carefully.
Thank you very much. Good question. Who have we got next?
Good afternoon. My name is Pat, registered nurse, and I've participated in palliative nursing for some period of my career, but not all of it. And I'm speaking now as a family. When my mother became palliative, she was in an intensive care unit, hooked up to everything. She had a difficult night, and as soon as I looked at her that morning, I knew that it was end of life within less than 24 hours. And after the family made a decision to not do any further treatment, we had to deal with three different physicians who, in their view, dying is a failure of theirs. How did the panel speak to that, please? With physicians, their view of, do everything to preserve life, and those not involved directly in palliative care view every death as a failure?
Absolutely. Palliative care is, I see it as a specialty, and it speaks to one of the points that I said before in terms of the appropriateness of care and care delivered by the right person at the right time. And it's not just a physician issue. Let's not be blaming physicians in ICU. That is their purpose, that is their job. And so there's always this internal conflict within healthcare about the curative path and the supportive or palliative path. So this is one of the dimensions in terms of when you consider where we go from here in building a framework, who is going to be at the table to build the framework, and then who will be at the end. Again, it comes back to that piece about why is that person in ICU in the first place? What could we have done before that?
I just wanted to say, in general, when Don and I were dealing with his oncologist, he had a neurosurgeon, radiation oncologist, medical oncologist. The oncologists as well don't like for you to talk about, we said, why are we doing this chemotherapy anyway? We know it's not going to help. Well, it might help your symptoms. And that was appealing to Don. If he just get rid of some of the symptoms. So we went through it all, of course, didn't do anything. And it was only the palliative care doctor, when he came into the house and sat down with us and he went, why exactly are you doing the chemo and radiation? And we're like, yeah, it was arranged for us. He was the only one who would actually have that conversation. I'm dying. I want to die the best death possible. How can you help me? So we just so appreciated that honesty. You can't make blanket statements about everybody, so I wouldn't say all oncologists were like ours, but have to, as healthcare workers in this room, we all have to be willing to what does the patient want.
Thank you very much. The Registered Nurses Association has generously decided to give the last few questions. We are running out of the public. So I want to ask, yes.
Good afternoon. I'm a little
not used to doing this. I may be in the autism spectrum, so bear with me. First off, I think we need a round of applause for the nurses in the room. I wouldn't be here without you. As somebody who has multiple disabilities, I enrolled for pain management in 2012 after a kidney stone blast that went wrong and my bladder almost burst. The hospital didn't want to help me. As well, I've seen good care and I've seen fantastic care, most recently Monday night with my wife who has a liver problem. So there's a definite range there. My concern is in patient care and ensuring that patients get heard and not funneled. In 1991, my stepfather was euthanized in front of me. And in 2006, my mother died of cancer, and I was with her when she died. We found out, my sister and I, afterwards, she had been abused by her husband. So given that we have those realities, I don't think this is a good way to go, no pun intended. I think we have alternatives, and the danger, and I think there is empirical data to support this, is that euthanasia will become the only option, pushed first, and then it will be everything else afterwards. And there's a real danger of abuse, organizationally and societally. Thank you.
Thank you very much. Yes, go ahead.
As an 84-year-old retired gerontologist, I would like to applaud the RNA for this move forward. I heard the video and watched the video of Dr. Donald Lowe, and some words of his stand in my mind. I wish every clinician could spend a day in my position. Thank you.
Thank you. Okay.
For la trade, they said to the family.
Yes, please, go ahead.
My name is Claudia Chavaniak. I'm from Ottawa. I'm an author. My story is Maureen Taylor's. A few weeks ago, I had to make end-of-life decisions for my husband. I was so impressed was at the palliative care community team that came every day to our home, helped us come to understand what death would be like. I believe that many people would feel less anxious and fearful about the concept of suicide if they were able to hear the kind of stories that Maureen speaks of, that I can. And my question is, how do we begin to educate grassroots community people about the positive benefits of palliative care and hospice services that already exist in our community?
Thank you very much. One questions.
My name is Keller, and I'm an author as well, and I've been commissioned to write a book on this very topic. So hearing you today has been amazingly inspirational for me. But my concern is yet to have a dialogue, as you've said, with the government on this very important topic. As RNA, is there a role you can play to have the Belgium process at least examined as an option for Canada instead of starting this whole thing from scratch? Because a year from now, we will be no further ahead than we are right now. And our
last question, please.
My name is Ruth Forbes. I'm a nurse. I work in palliative care. Nurses, we need to educate ourselves with information that is correct and in disseminating information that is correct to our patients to alleviate their fears and so that they are well informed. My premise is that dying is relational. You have to be right with God and man before you die. How do we help people do that? Well, I think we need to consider first the context that Canada is operating under right now. We are one of 126 countries in the world. 4 to 6 jurisdictions in the world have legalized euthanasia. When I looked at the Supreme Court decision, I was stunned by the words in the introduction, which set up that people have two options and two options. That is to die in agony or to. I felt disenfranchised as a palliative care nurse for the work that we do. And I wondered if our Supreme Court justices understand what palliative care can offer. We need to be very careful not to fearmonger. We need to understand our own feelings. We need to understand our own opinions, what they're based on. Do we understand ethical principles? Not just of autonomy, because we are human beings, we live in a relationship. We do not exist with a me-first attitude. We have to have family-centered decision-making. And those are some of those contexts. One final thing is
I'm really sorry. I have to cut this off, but the questions you're asking are the questions that Canadians are going to be wrestling with for the next year as they figure out where they want to go with the Supreme Court's decision. It's made. It cannot be undone. But we can put in place process and options and well-funded alternatives. The Supreme Court didn't place any limit on that. So your conversation is the beginning of a conversation we're all going to have. And I think the people in this room deserve a round of applause from the public who unfortunately aren't here. For giving us such an honest, respectful model from which to proceed. So I would like to thank you very much and pass the microphone back to Doris.
So, first of all I can say is thank goodness Carol was moderating this. She was like a stickler with the 3 minutes. And thank goodness I was not sitting there because I would not have been able to do 3 minutes. And thank you to all of you. I hear from my staff, this room can hold 400 people, but we have rows in the back. I hear we have 500 people today. Let me share with you that we already had 2 webinars that were only for nurses, for members of RNAO, and we had 500 people participating in these webinars. We will now proceed with webinars open to the public because this that needs to continue to be discussed. So for those of you that are representing the public, please know nurses, and we at RNAO, because I believe we are the only organization so far in the health professions overall, RNAO, that has opened a forum like this for the public. We will continue to pursue public discussions for 2 very important reasons. All because the decision has been made. And so there are 2 critical factors that you spoke today that are absolutely essential given the decision. One is that this country, and certainly Ontario is part of it, needs to improve his palliative care access across every corner, every region, every community, to be way more than what it is, both in terms of access and education and capacity building. So that's number 1. And second, that we develop, and yes, we have discussed this already with Kathleen Wynne, the Premier, because if the Prime Minister decides to do nothing on the court decision, that should not be the case of Ontario, that we do develop an ethical principle framework around the court decision so people feel comfortable in all sides of the equation. I do want to, though, have nurses not leave here with one piece of information that it is in the resolution of RNO. And it is that we at RNO believe no nurse should be obliged to participate if that nurse doesn't have the competencies or the expertise, but also that person cannot simply say, I'm out of here. So all these things need to be discussed in a framework because a decision was made. We cannot leave the public without access to their choices. We cannot leave the public with access to their choices in two ways, in terms of top-notch palliative care and in terms of what might be their choice regarding assisted dying despite of optimal palliative care. And I think, Maureen, you brought it so well to the forefront from a family perspective, and I think some of our colleagues, including our colleague from medicine, our colleague gerontologist, I don't know your name, sorry. So I think the debate needs to be open, needs to be vibrant, needs to be. We need to stop the fear mongering, I think, as someone said, from all ends, and we need to enable what Vanessa said, the respect for autonomy and for choice. And I think, Peter, you said that well, while not driving that because there is not good palliative care. That really is very important. So thank you to all of you. Stay tuned. Visit the website. We will have webinars starting in the fall, and we will have them frequently. Because if governments are afraid of engaging in the dialogue, we are not. Thank you. And a token of our appreciation. Gorgeous orchids.
I think to myself,